labor and when you're pushing. Also considering, thinking back last week when we went through the stages of labor and that first stage that can be several hours for some people, how long that process is can affect your ability to tolerate certain positions, right? So I'll have patients talk about, oh, I heard it's really good to squat for labor and for pushing. And then I'll ask them, oh, when's the last time you held a deep squat for 30 minutes to an hour, depending on how long you're going to push for. And, you know, usually people don't hang out in that position unless you're my mom and you're watering the grass or something. She loves to do that in a squat for some reason. But it's a difficult position for a lot of people to achieve. So you want to just keep that in mind, especially when you're practicing birthing positions throughout your pregnancy, to see what's comfortable for you. And then thinking about any available equipment or amenities in the birthing facility, or that you can bring with you, like a birth ball or a peanut, which I'll show some pictures of later. And then energy conservation. So I always tell patients and people who take my childbirth class that a birthing position can mean a position you're in for labor or for pushing. So labor, you want to be active, you want to have variety, you want to use gravity, you want to be comfortable, but you also want to rest when you can, because again, that phase might last for several hours, so that when you get to the pushing stage, you're not fatigued and already tuckered out from being super active. So you definitely want to think about how much energy you're going to have available when you get to the part where you're actually pushing. And I have a couple of basic principles here. So last week we talked a ton about constipation and toileting, which is great. And we have this image in one of our handouts for patients where we show proper toileting posture. So you can see the toilet, you can see the footrest. So Linda talked about the squatty potty. So you could see that you want something under the feet here to make the knees higher than the hips. And then you want the belly bulged outward to release the pelvic floor, which I'll talk about when we talk about pushing. But basically the knees higher than the hips and the ankles slightly wider than the knees. That's another thing that people don't think about, is helpful to open the pelvic outlet. So the pelvic outlet refers to this pelvis. You look at it from the top and from the front, this ring is the inlet. Versus when you look from behind, where you have these two little bony prominences and where the tailbone would be, that would be more of the outlet. So for baby to travel from the inlet to the outlet, you want to be in positions that open that bottom area. So this is pretty rigid in life, but during labor, a lot of hormones help make this a lot more flexible. So not only do your hip bones tend to separate a little bit, but your sacrum, which is back here, tends to move out of the way slightly as well. So keeping the knees flexed up and the knees slightly inward compared to the ankles will help to open up this back area. So just something to consider. And obviously having external support is super helpful, whether that's a partner or a doula or equipment, to just help you move in and out of those positions. Just remember to be safe and to practice these early on so you're not knocking things over in the delivery room. So I have the same picture in several, I guess, positions or alignments to show that you can have, you know, sitting in on a toilet with a footrest can look like a squat when you bring the legs up. Same concept when you're on your back versus when you're on all fours. So thinking about this angle, still replicated in this posture, even though this person is technically laying on their back now with their knees up, versus this person who can be on hands and knees, and they can be resting either on their arms, on a pillow, on a birth ball, or a peanut, just to show you that the basic principles still apply. It's just whatever is most comfortable for you. Okay. So for the birth ball, you just want to make sure that you size it based on your height, because if it's way too big and you try to sit on it, your little feet might be dangling, which is not safe. And same goes for the peanut, so making sure that it's appropriate or proportional to your size, and making sure that it's burst resistant. So burst resistant doesn't mean it's not going to pop. It just means that if something does nick it and it creates a hole where air can escape, it won't just rupture, it'll deflate slowly, which is definitely what you want. For the peanut, we don't suggest that you sit on these or straddle them. They can't really tolerate a lot of pressure unless you're a child, but you can use them in the bed. So if you do end up getting an epidural and you can't necessarily walk around, you can still utilize a couple different positions with the peanut in the bed. So I'll show those in the next slide. But yeah, basic birth ball and peanut. And A couple of other options are the rebozo garment, which is originated from the indigenous Mexican practices of medicinal, basically they're medicinal cultures, where you can use that kind of as an external support to help decompress or offload the belly and the spine. Or you can even see that, you know, playing a little bit of tug of war can sometimes help generate more strength to help with the pushing phase. And then you also have the squat bar, which is available at a lot of facilities these days. Most typically, you think of it being used this way, right? When you're actually doing a squat in the bed with some assistance, so you don't have to hold your body weight up completely. But I like these images because you can use them in different ways. So you can be on your side like this person here with one leg up with support, using a rebozo or a garment to help with the upper body strength to direct some pressure downward. Same thing up here. So lots of different options. The biggest thing is to practice beforehand. You don't want to go into labor never having experimented with these things because you might not know how it feels until you do it in that moment. So it's good to practice ahead of time and figure out what feels natural and comfortable for your body. All right, so here are a couple of birthing positions. So the first ones at the top are obviously more in bed. So you can have the partner behind you. You can have yourself on your side with the peanut or a stack of pillows between your legs. You can also have the partner behind with the leg hoisted up. And then you can still make nice eye contact there and still coach your partner through some of that. And then you can go on hands and knees, but hands and knees can be variable depending on what equipment you have available, which is shown here with the bed being elevated versus using a ball, right? So the ball's kind of nice because you can sway and you can rock and you can bounce. But then obviously the stability of the bed is also nice if the contractions are pretty intense. And then you have some seated positions. So either on the ball, partner assisted, on the toilet, or on a chair. I like the backwards facing on the chair. You can also apply that position to the toilet, right? If you put a pillow on the backrest of the toilet and lean forward, you have the hollow cutout of the toilet seat where you naturally will feel some relaxation, and you can kind of cue the pelvic floor and all the tissues to release in that position as well. And you can go to the bathroom if you need to. On this slide, we have some upright positions. So again, thinking about gravity, you want to use gravity to help baby drop into the pelvis to engage into the birth canal. So you can have the partner behind supporting, you can have a leg up, which gives a nice stretch to the pelvic outlet and the pelvic floor muscles, or you can be squatted like in these positions, either using something for support, using a partner behind you, or I didn't draw it out on this slide, but you can have the birthing person in a squat, but facing the partner and leaning forward, which is sometimes a really nice one, because in that position, the partner can massage the shoulders or the neck or the scalp, which can be really, really relaxing. So that's a nice one. Or using some traction and holding the upper extremities while the partner drops all the way down to the floor is also helpful. And leaned forward on either a ball or, you know, even just a chair with your arms supported, or a stack of pillows is sometimes really comfortable as well. Kind of take some pressure off of the low back there. So yeah, as you can see, it's all the same principles of using gravity, opening the pelvis, relaxing the muscles, and then you just kind of figure out what you like and what you don't like, and you have a ton of options to use during labor. So think of practicing these positions as a dress rehearsal, so you're not doing the awkward like, oh, where do you want to go now? Because the partners usually have to help with the transitions. So for pushing strategies, I wanted to go over some basic Kegel principles. So a big part of our job as pelvic PTs is to teach people how to properly contract and relax their pelvic floor. So a pure Kegel is a squeeze and a lift of the muscles. And you can see here, oops, I guess if I can play it, I guess it won't play. So you can see on this image, there's the yellow opening, which represents the urethra, the pink, which represents the vaginal opening, and then the anal opening down here. When these muscles squeeze or you do a Kegel, you'll see these openings close, and then you'll see a lift inward. So you coordinate this with the breath, which we'll talk about in the next slide. You inhale to stretch the muscles, and you exhale to squeeze them if you're doing a Kegel. A couple of verbal and visual cues that we give in the clinic include putting your sit bones together. So on either side here, this person's on their back, so their sit bones are visible. Imagine pulling these together, or pubic bone and tailbone together versus tailbone or pubic bone together. And for those of you who have experience with a tampon, sometimes imagining a tampon in the vaginal canal and trying to squeeze and lift it up into the body is sometimes a helpful way to think about that. Or some people use the analogy of a straw in your vagina and trying to drink a smoothie up inward using that Kegel motion. So if you wanted to try that, you can follow it up with the breath, which is on this slide. So on the bottom, you can see as somebody takes a deep breath in, the diaphragm, which is at the base of the rib cage, pulls down, which causes the belly to expand and the pelvic floor to then relatively drop because of the pressure change. So as you inhale, you can try it right now. Take a deep breath into your belly. So if you do yoga, it's that belly breath where you expand. And imagine all that air expands into your pelvis and causes the muscles to kind of melt or release a little bit. Now, as you exhale to let the air out, that's when you want to activate the pelvic floor and pull the abs in to then direct that air back out of the lungs. So inhale to expand, exhale to then squeeze and lift the pelvic floor. So trying that a couple of different times, alternating between the inhale and the exhale can be very helpful. If you have trouble with that, come to the workshop tomorrow and we'll go over that in way more detail, but definitely good to just experiment and practice for anybody, pregnant or not. So life skills for life. Learn how to do Kegels properly. All right, so for pushing, how does this play a role? So the thing about pushing is you want to make sure that the pelvic floor is relaxed, the pressure is being directed downward, and that you are not necessarily holding your breath the whole time. So I have two representations here of how you can push. One is using the exhale. So you can see here the open glottis refers to exhaling through the throat, and that also allows you to vocalize. So if you wanted to exhale and moan or use a low tone sound or scream, vocalization is helpful to relax that pelvic floor as well. So the cue that I give for that is inhale, make your belly big. But since now we're working on pushing and not kegling, you want to keep the belly big as you exhale. So I use the term inhale, make your belly big, and as you exhale, make your belly bigger. So inhale, belly big, exhale, belly bigger. And that should kind of feel like when you're trying to pass gas and you try to force something out that way, you might feel that drop in the pelvic floor. Versus if you were to do that same thing, but instead of exhaling, you kind of catch your breath and you hold it in your throat as you continue to push downward. So if you inhale and make your belly big, exhale a little bit of air and then catch it. So you'll notice a change in the pelvic floor. For some people, they feel the pelvic floor go and release. For other people, the pelvic floor actually reflexively goes as you catch your breath. So we call this the Valsalva maneuver, which is when you hold your breath and bear down. So this technique can be very powerful for some people, but it can also be very inefficient if the pelvic floor muscles are not fully released or relaxed. So it can be more exhausting as well when you're constantly holding your breath and cutting off some of that blood supply. So you definitely want to reserve the holding the breath type of pushing for maybe the very end when your baby's already crowning and you just have 2 pushes left. It's definitely not something you want to do repeatedly for hours because it can be very, very draining on the body. So 2 strategies for pushing, but both represent the same exact mechanics. It just depends on what you feel. The purpose of the pelvic health PT sessions, we can help you determine which strategy is best for you, especially because some people are starting with a limited experience with contracting and releasing the pelvic floor muscles. So if you've never done a Kegel in your life, this can be very confusing and feel really difficult to differentiate. So we can work with you that way too, but just something to try. So either inhale belly big, exhale belly bigger, or inhale belly big, exhale, catch the breath and continue to push down and see how you feel. All right. So moving forward. So the last thing I'm going to talk about is training the pelvic floor muscles. So the thing about pelvic floor exercises is everybody thinks it's a Kegel, which is partially true, but you also want good dynamic flexibility in the muscle. So the ability to relax the pelvic floor is required to do these exercises properly. So that inhaling to make the belly big is really important before you do any strengthening. Because if you think about the muscles in the jaw as an example, if you're clenching your jaw and I ask you to bite down, you can't really produce much more force because you're already tensing those muscles. So you would technically need to first relax the jaw and then produce that nice strong bite down to then activate the muscles. So same concept applies to the pelvic floor. You want length or flexibility before the strength. And with the strengthening, you want to increase the strength of the muscle fibers and create hypertrophy, which is a word for thickening of the muscle fibers, to then make them stronger and more resistant to tearing when you give birth. So down here, you can see how much the pelvic floor has to stretch. Muscles that are strong and well conditioned and have good blood supply are less likely to tear. So that doesn't necessarily mean you do 1,000 Kegels a day. It means that whenever you do a Kegel, you understand how to also release the tension and then squeeze and lift back up. You're strengthening the cross bridges, which the fibers in the pelvic floor muscles, they attach through those cross bridges, and the stronger those are, no matter how much stretch, they hold tight. So you have the flexibility to give without rupturing, which is what you want for vaginal childbirth. And then for coordination, we give a variety of different types of Kegels. So you can imagine squeezing and holding for 10 seconds. That's kind of the standard Kegel out there on the internet. But you can also do quick contractions, which is less of a hold and more of a pulsing. So pinch, relax, pinch, relax, pinch, relax, versus an endurance hold, which is when you squeeze and you hold for a set amount of time. And then the last part of the puzzle is maximal versus submaximal. So I tell people, you know, muscles don't always behave in an all or nothing pattern. So if you've ever tried to lift a can of, I don't know, soda or a beverage off of a surface and you didn't realize that it was already empty, you might overshoot it and then use way too much force than necessary. So it can be a good or bad thing, especially if you spill, but you don't want to just train the muscles in such an aggressive way. You want to also be able to grade how much force you're producing by doing max contractions and also maybe 50% effort contractions, right? Also training with a cough or a sneeze to make sure the muscles can support against that increased pressure. So all of this we go over in our PT sessions, but just to give you a general understanding of why the pelvic floor muscle training is important and why it's not enough to just do plain squeeze, relax, squeeze, relax, squeeze, relax, right? So it's a good start, but there's definitely more to it than that. So lastly here, I have an example of a home program that I might give somebody with semi-decent pelvic floor strength. Think of a circuit where you have 3 different exercises and you do a couple of sets of each in a row, and then you repeat that as needed. So for example, down here we have the quick flicks. I might tell somebody, okay, squeeze, relax, pulse, pulse, pulse about 5 times in a row. Take a deep breath to release the pelvic floor tensions before you move on to the second type of exercise, which is where you squeeze and you hold the muscles for about 5 seconds at 50% of your maximum effort. So if I told somebody, squeeze your pelvic floor as hard as you can, and they get what that feels like and they feel that lift, and then I ask them, okay, squeeze the same, but only half amount of that effort, and they usually will sometimes feel that difference, and then I tell them just hold that amount of tension 5 times in a row. And then again, release the tension in between that exercise before you move to the last version, which is, I tell people that this is the go for broke exercise, where you squeeze and hold 100% effort for as long as you can. For some people, that's 8 seconds. For some people, that's 18 seconds, right? And then you get a variety of different types of Kegels in one exercise circuit. And depending on the person's endurance and how well they can coordinate that, I might have them do that 2 times, you know, that whole circuit twice. And then when they get stronger, we can increase that amount or progress to different positions and add some dynamic movements, like maybe balancing on one leg, or while you're doing a squat, or while you're bending forward. So you can train the muscles with those dynamic movements as this becomes more easy for the person. So yeah, just an example of one type of program. It's really important to talk to pelvic PT first before trying a specific type of program to make sure it's appropriate for you, especially if you're already having some symptoms of urinary frequency or pelvic pain. So all the stuff we've already talked about, you want to make sure that you're doing the appropriate type of exercise for your muscles so you don't make anything worse. All right, so I think that's it for me. So I'm going to hand it off to Linda. Who's still muted.
Okay, give me 1 second. Okay, can you see my screen?
Yep.
Okay, so Thank you for coming back. My name's Linda. So part 3 of postpartum today, we're going to go over pelvic organ prolapse, diastasis recti, some self-screening tools for both, some symptom management, as well as some general core strengthening for the postpartum population. So first off, pelvic organ prolapse. What it is essentially a descent of one or more of the pelvic organs or structures that fall into or through the vaginal canal. So if you think about, I tell people thinking about pantyhose, right? If this is the vaginal canal here, all your organs sit inside here. And what happens following delivery or weakness or surgery or anything of the sort we'll go through is the walls here get thin, and then you get a little bit of an inversion of something or something falling through the wall of the vaginal canal. So prevalence, 1 in 5 women in the United States have a pelvic floor dysfunction, and 3% of that, of those women have pelvic organ prolapse. It's not as common as urinary frequency, I'm sorry. Okay, my laptop's being funny. Is it back on? Okay, so I did a quick poll. So in 2017, there were 165 million women in the US. 3% of that puts us at 4.95 million women who suffer from pelvic organ prolapse. So that's a good amount of people to kind of think about. So risk factors and causes. Age, race, ethnicity have been proven to be some risk factors, as well as obesity, just because there will be extra pressure and gravity kind of pulls one way as well. And childbirth, so vaginal birth versus C-section, as well as multiple births and trauma, and looking at increased intra-abdominal pressure. So this kind of goes back to, from a female perspective, if there's prolonged pushing, if forceps were used, if all of those cases happen during a vaginal birth, there could be some nerve damage, there could be some tissue damage, which causes a decrease in muscle tone or laxity in tissue. As well as in men, there could be heavy lifting, men or women. Heavy lifting is a really big one where we hear about the Valsalva a lot. And don't get me wrong, Valsalva has their place if the person is bracing their core correctly. However, with novice Valsalva maneuvers, what happens is, if you guys remember from Q's slides, there's a lot of pressure coming down this canister. The walls here aren't necessarily strong enough, and if they are, then they push in, there's pressure here, and your pelvic floor on the bottom does not generate enough force to push back up. So now you have a descent of some structures from the pelvic floor. Menopause, just because there's a change in estrogen levels. Estrogen is very prominent in women, and when there's a decrease, we look at tissue change, and if tissue thins, then there's a dexterity difference in tissue intensity. And then pelvic traumas and surgeries, like we spoke about, such as hysterectomies, C-sections, and all of those things, sometimes may play a role, as well as connective tissue disorders. So Marfan syndrome, Ehlers-Danlos, increased hypermobility that is congenital can lead to increased risk for pelvic organ prolapse. So, okay, sorry, really quick. If you take a look at all of these right here, this top left photo shows all these shows a side view. However, this one is in an anatomy without prolapse. So just really quick, uterus, bladder, vaginal canal is this thin red line right here, urethra, and the vaginal openings right here. Okay, this is the rectum, this is the anus. Now, with no prolapse, everything stays within this line. So if you look at a cystocele, that is a descent of the bladder. So the bladder comes forward and it falls into where that vaginal canal was. And some people will see a bulge in the front, what we call an anterior prolapse. There'll be a rectocele where the rectum, again, the back wall here, falls forward. So the anus is still here. It is falling forward into the vaginal canal, and there's a bulge there. There's also uterine prolapse where the uterus itself, so if you look at this, it's kind of looking like a golf club, where the uterus itself, because of increased pressure or what have you that has happened, has now come down, descended into the vaginal canal. There's an enterocele where we talk about a gap that has happened, which allowed the intestinal lining to fall through, and then a vaginal vault where there's an inversion. Okay, So pelvic organ prolapse, the signs and symptoms. Majority of the time, patients will come in talking about vaginal pressure or discomfort. A big one is feeling like there's a bowling ball or something that's in or at the vaginal opening. There's a protrusion or an actual physical bulge. So if you look at the picture on the right, this is actually a cystocele where the bladder is falling forward. Okay, and if you open the vaginal canal and you have this person push, you'll see this bulge that comes out. This is the urethra. The vagina is still there, okay? It is just now just kind of taking the place of it. You could essentially go in and move it, excuse me. So some other signs and symptoms will be positional changes to start or complete emptying, whether it is urinary or fecal. So some women will talk about, well, I can sit here and go, but at the end I kind of have to bend forward, or I have to push at the lower abdominals, or I have to lean back. So depending on what the anatomy is and where everything is, those can be some signs and symptoms. There's feeling of incomplete emptying. So again, if the bladder has fallen into the vaginal canal, you can see how there would be a pressure change in how urine is flowing out of the urethra, where now there's lower pressure here. You'll still feel the fluid, but there isn't enough pressure to generate it out unless you push or something of the sort. Urinary changes. Urinary incontinence, stress or urge are some signs. Frequency and urgency because there is increased heaviness in that region. Post-void dribbles. So if you notice that you go to the restroom, you sit down, you go, and you feel like you're pretty empty, and you clean up, you stand up, or even in the middle of trying to pull the bottoms up, there's a little bit more that comes out unknowingly. That is a potential sign. There will be some sexual changes as well. Doesn't happen to everybody, but there could be pain with penetration, difficulty with orgasm, sensitivity in the vulvar region as well as the vaginal canal, things to again keep an eye on. Lower back discomfort as the day progresses. Some women will talk about they feel fine, and if they've stood too long or they've done a lot of heavy lifting, they'll feel increased lower back pain that's a little naggy with the pelvic bulging or heaviness that relieves itself with sitting or generally laying down, okay? So self-screening. I'm very big in the clinic on getting to know your anatomy. Not everybody's ready for this. However, if you are curious, what you can do is take a visual screen, okay? So items you'll need: handheld mirror, gloves or washed hands, and then your eyeballs. So the steps go, you wanna lay on your back, nice and comfortable. Knees are out to your side or butterfly, whichever you prefer, okay? Something comfortable. You take the mirror and you place it in front of the vaginal opening. You spread the labia apart and find the vaginal opening. So from there, you'll do a quick cough or a gentle bear down. Again, gentle is key. And you look for a bulge, okay? You can also repeat these steps in standing. Generally speaking, I'll have someone do that in the restroom where they can put a foot over the cover of the toilet or over the ledge of the tub. And what you're looking for, if you look on this screen right here, is a vaginal bulge. Where there's no bulge, okay, a mild bulge, you see something that may be peeping through. There is something at the vaginal opening, or there is a bulge, and definitely that does come out, okay? Symptom management. So with pelvic PT, we talk about coordination and training of your abdominals, your diaphragm, your pelvic floor. So kind of this canister that we have talked about earlier as well, and some core and glute strengthening to make sure that we keep everything up and in. Okay, and then we will go over some bowel and bladder habits. Some other things to take a look at is lifestyle and diet modifications. So decreasing constipation, because that decreases straining. Okay, the goal is to decrease the amount of unneeded strain in that diaphragm region to push everything downward. Okay, weight management if that is a cause. And then looking at pressure management. So intra-abdominal pressure management of being able to contract the pelvic floor to fight all this downward pressure that comes on when we do lift and carry, when we do cough and stuff like that. Avoiding Valsalva maneuvers. So I put this little asterisk there because, again, Valsalva maneuver has their place in a lot of Olympic weightlifting, heavy weightlifting, and I'm not against all of that. It is just more of the coordination piece of understanding, can you get your abdominals and your pelvic floor to coordinate all of that before your lift to protect yourself, just as Q was saying in the last couple slides. So mechanical support, there are things out there such as support belts that you wear. They kind of look like female versions of jock straps that kind of help push up and give that perineal and pelvic region some support. There is something called a pessary. It's an internal mechanism that your provider OB can fit you for, something to talk to them about if you feel like that is something you need. And then there are some surgical procedures out there that, again, you can consult your OB about. Okay. Okay, give me 1 second. Oh. Sorry guys, internet problems. Okay, so next up, diastasis recti. We hear this a lot. This is essentially the separation of the abdominal muscles at the linea alba. So really quick, if you look at this right side, this is kind of a layered dissection of the abdominal muscles, okay? So first off, you have this thick fibrous tissue on the outside. You cut that back. This is your rectus abdominis. This is that six-pack muscle everybody talks about. And this is the belly button. Okay, and deep to that, you have your transverse abdominis. We have your internal and external obliques that help us side bend and rotate. Okay, now with a diastasis recti, this thick connective tissue right here is what separates. Okay, so the prevalence of a DRA, what we call in short in the clinic, is there was a study done that they found 27% of women in the second trimester had a diastasis recti, 66% in their third trimester of the pregnancy, and 36% remained after 7 weeks postpartum. So common thing we do see following pregnancy, just because there is baby is growing and the body kind of makes a decision of keeping it aesthetically pretty or allow baby to grow, and generally baby always wins. So that's also something to think about. So risk factors and causes, again, we talked about pregnancy, so multiple pregnancies, C-section versus vaginal delivery, as well as how big and heavy baby was during your pregnancy. And it depends on the person, because some moms are, 5'2" and have a 10-pound baby, and some moms are 6'2" and have a 10-pound baby. So everybody's genetic makeup is a little bit different. Heavy lifting is a really big one. We talked about intra-abdominal pressure management. Weight gain, weight loss is a big one. Repetitive heavy lifting, poor pressure management. So if you look at these two, this is a normal rectus abdominis, sorry. So everything's nice and pulled together and abdominals are by their side. Now, during pregnancy, again, we have to make room for baby. And with the amount of hormones that are rushing through the body, we look at the laxity of the tissue allowing fetus to grow. So you will see this, it is very common. Signs and symptoms are really low back pain. You'll see poor posture. People talk about this abdominal pooch that is low hanging or they can't get rid of. There may be a bulge, what we call doming or tenting, when you are in a sit-up position. So some moms will notice it when they have to get up really quickly from bed because baby is crying, and they'll see this bulge kind of lower into the midsection. You'll feel weakness in the abdominals, may or may not have abdominal pain or discomfort. Okay, so these are types of diastasis recti. They just kind of happen in different areas. Again, there's no rhyme or reason, just more so of lifestyle, habit, and then genetic makeup. So normal abdomen without a diastasis. So then you have diastasis at the umbilicus, which is just at the belly button, which is mostly the common one we see. And then you'll have one below the belly button. We have above it. And then there's one that runs the full length of the linea alba. Okay. So self-screening. There's a couple ways to do this at home. I was trying to see if I can load the video, but I guess I can send a link out with it. So if you are looking to screen, what you want to do is you want to lay on your back with your knees bent and feet flat. So you want to be in this position. You're going to gently press down with your fingers. I generally tell people 2 fingers is nice. And I generally tell people from breastbone to pubic bone, because if you remember that diagram from before, our abdominals really run from like the base of where the bra is to right above your pubic bone, and attaches through the length of that. And from there, what we're feeling for is any tension and any softness. If you're like, okay, tense, oh, there's a little bit of sinking or a squishy feeling, I would say. That's somewhere you want to kind of keep in mind. From there, you gently lift your head, neck, and shoulders like she's doing a mini curl up right here. Okay, and it's gentle and really small. I tell people like 20, 30 degrees. You don't have to go into a full sit up. And then you want to feel if there is a bulge or a squishy piece. And then if you go side to side from the belly button, you'll feel the tension of your rectus abdominis. Okay, so we will look at, in PT, we look at the width, the depth, and the length. Okay, that'll kind of give us a little bit more information as to what's going on. Generally speaking, we do care about the width. However, we're really looking for depth. I would like, generally for patients, that after they leave me and they're done with PT, that they have a good trampoline feeling where the separation is, because that's telling me they're generating enough force to protect that abdominal region. So symptom management, again, we talk about pressure management, the breathing pattern that Q had spoken about at the end of her slideshow, as well as decreasing breath holding and Valsalva. And some women benefit a lot from using an abdominal binder. So that just early on postpartum, it just kind of helps hold everything together for some external support, because there is still the lifting and lowering that needs to happen. There is still breastfeeding that needs to happen, and life in general. So having some support might be nice. Strengthening. So we will also look at core, glute, and pelvic floor strengthening. So a couple slides back, we talked about how there's a big canister around this region. We've been talking so heavily on the pelvic floor. However, if you think about the sides of the can, they have to be intact and coordinated in order to keep everything upright as well. So we look at motor patterning of breath, core, pelvic floor, glute for certain functional movements. If there is return, we do some return to sport training. If there is a sport someone wants to return to, whether it is running or volleyball or whatever it is, we take a look at the movement science behind that and how to train you in that, as well as looking at functional movements. So we will talk about, in PT, we talk about bed mobility, transfer, lift and lowers, and activities of daily living. So knowing how to get in and out of bed correctly without aggravating your abdominals or your pelvic floor, understanding how to get in and out of a car, or lifting and lowering baby from either a bassinet, the floor, the crib, as well as daily activities such as loading and unloading the dishwasher. Okay, so those are some things that we do go over in PT. Okay, and I'm stuck again. Okay, sorry guys. Okay, so last thing to kind of go over is your transverse abdominis. I explain this as the deepest layer of the pelvic, of the abdominal girdle, and it holds you together like a corset. Okay, the fibers run this way, and the goal is to tension everything and close the doors. So something to try if you are somewhere, you can lay on your back, or you can do this in sitting. Okay, I want you to try to inhale first to relax the muscles. When you breathe out, begin to gently draw the abdominal muscles in as if someone was tickling you. Okay, envision your muscles moving inward and draw the belly button toward your spine. You may or may not feel a pelvic floor contraction, okay? And you can imagine zipping up a tight pair of jeans as you draw that belly back. Once the muscles are engaged there and you've drawn that belly button back, go ahead and take a normal breath for me, maintaining the tension through the abdominals. Some cues I usually give in clinic are, as you exhale, go ahead and do a shh. That generally will draw that belly in. Or think about blowing out candles. Get ready for your next birthday and really kind of drag that breath, purse your lips, and blow those candles out. And you should feel some tensing in the lower abdominals. To check if that is the case, you want to place 2 fingers below 2 inches below the most prominent part of your hip bone, okay? And as you exhale and draw that belly in, you should feel the muscle tense up underneath your fingers and pull away from it. So something to try. And we have progressions for all of that as well. And then lastly, okay. So I'm gonna, there it is. Okay, so lifting mechanics. So really quick, this is actually something I'm really passionate about for postpartum moms because of the amount of lifting and lowering we all do. So techniques to avoid are on the left. the one hip hold. A lot of times I call it the mommy hip. You prop baby on one hip. Usually it's your non-dominant side so that you can have your dominant hand to do things. And I tell people this is not wrong. It is just you don't want to be in that sustained position for a long time, because if you're propping baby into a hip, we're really putting weight and all of our stability through the hip joint, and you're really not working any muscles, as well as lifting with your back. So if you see mom right here, she's curved through, knees are slightly bent. It puts her lower back in a really precarious position to get injured. Okay, so this over here is one of those techniques we do work on, but again, we do modify depending on mom and comorbidities and past history of injuries. Generally, the goal is trying to stay in line in the spine. You don't have to be upright. I just care about people being in line and making sure you're using your hips and your knees to lift baby as you come up or down. Okay. And then over here, last little tidbit is arching lower back. So a lot of the times, not even just with baby, but if there's anything heavy that we have to carry, a lot of the times we throw it into our chest and we puff the chest up because we're sitting the weight into our spine, and that causes a lot of lower back problems. So thinking about when we carry baby, it's constant weightlifting. So they do get heavy. So making sure the abdominals are engaged and the glutes are engaged to make sure the lower back is not taking the brunt of it. And those are, again, some of the mechanics and things that we will go through in PT. Okay, so before I screw that up, I'm going to pass it on to Pizzy.
Hello, thank you, Linda. Okay. Okay, so week 3 for pediatrics. I'm gonna first talk a bit about breathing and show you a video of a breathing exercise you can do with your kiddos. I'm also gonna do the bowel massage I talked about last week. We're gonna go through a few exercises that I love to help influence pelvic health in kids. As you might remember from last week, I'm not a huge fan of just having children do Kegels for the sake of it. I think that if that's necessary, it really should be an expert telling you guys that they need to do it. So these exercises are going to be more just to help with general core strengthening, hip strengthening, and good stability of the pelvic floor. And then lastly, I will be giving some helpful resources for parents to help with managing bowel and bladder function in their kids. So first, breathing. So as you've probably gotten the gist through all of our weeks and all 3 topics, really, breathing is a really big deal when it comes to pelvic health. There's a very strong relationship between the diaphragm and the pelvic floor. So when we're talking about kiddos with pelvic floor dysfunction, breathing exercises are really going to be a big part of their program. So I have kiddos practice belly breathing and breathing in with their nose and out with their mouth. And you'll see a video of that in a second. Blowing bubbles can be a great way, really encouraging the kids to inhale through their nose and exhale through their mouth. Same with blowing a pinwheel. Older kiddos that can blow up a balloon, this can be good practice. And then one thing that I've kind of created on my own with my own kids is something I call the big bad wolf, where I have a child breathe in through their nose and make their belly really big, like they're preparing to blow a house down. And I sit in front of them and I ask them to try to knock me over with their blowout. So we pretend that they're the big bad wolf and they're trying to blow me over. And we're just really trying to encourage a nice deep belly breath, get all that air in, and then try to blow me over. And I watch how they're doing it. And if I'm happy with the way they inhaled, then I let them blow me over and I fall backwards. So I find that this can be kind of an engaging way to really get kids to work on this. And I even with my own child I've done it while he's sitting on the potty. I'll sit in front of him, and to get him to breathe, I'll have him and we do this activity sometimes, and it can be a bit fun. So meditation is another a big thing that I will ask some parents to try to get their kids involved with. I'm seeing more and more of it being done in schools, which is great. But meditation can be powerful for children because it's going to encourage good breathing habits. It's going to teach them to listen to their own body. It's going to get usually some muscle relaxation, relieve stress and anxiety, and just to unplug and really learn to quiet themselves. It can be powerful. It doesn't have to be very long. It can be just 1 or 2 minutes, or it could be a half an hour. It really depends on the child. But there's lots of great resources out there. There's loads of free videos on YouTube. Some of the apps, the free apps you can get, what are some of them? Breathe and Headspace. You can apply those. Insight Timer definitely has some for children. You can apply those for children as well. So here is a video of belly breathing. So this is my son. And he's going to demonstrate breathing in through his nose and out through his mouth. And I have them put a hand on their chest and a hand on their belly. And I ask them to make their belly hand move when they breathe in, not their chest hand. So he's getting some good belly breaths in right there. You can also put a stuffed animal on a child's belly, and that can encourage them to lift the stuffed animal up and down. I've even heard of some therapists putting a very light weight to kind of give them a bit more feedback. You can put your own hand there, but that can be a great exercise. And once a kid really has this down, this is where it's going to be very helpful on the toilet, where you can ask them to do their belly breathing as they're sitting in their potty posture. And that can really help the pelvic floor to relax so they can have a good bowel movement or empty their bladder. So next is the bowel massage, and I talked about that as part of a bowel routine that with children with constipation, doing a bit of a belly massage can be very helpful. So what we tend to do is something called the ILU, or the I love you massage. And what it's doing is it's tracing out the shape of the colon. So the colon, or the large intestine, is basically an upside down U shape. You have your ascending colon here, your transverse colon here, descending colon here, and then the sigmoid colon comes down and meets at the rectum. And so the idea of the bowel massage is to try to assist the muscles that are trying to push the stool through the large intestine. It's trying to help give it a little extra oomph using some massage. So with the name ILU, those are the letters that you're going to be tracing out over the child's stomach. You can also do this on yourself. We might have even touched on that earlier for doing it on your own. And I'll show you a video in a second, but we want to do the letter I first, which means you're going to be sweeping down from the top left down to the bottom left. Then the letter L, where you're sweeping across from right to left and down. And then then you're going to do an upside down U, I should say, starting from the bottom right up to the top, over and down, and maybe even adding a little extra just to sweep back across towards where the sigmoid colon meets the rectum. So you're going to see me do this with pressure. You really want it to be gentle pressure. I call it gentle but assertive. I mean, you don't want to be so gentle that you're tickling them, because they are going to be ticklish, I will say. But obviously you don't want it to be painful. And even with any type of pressure, if a child's noting pain, then you want to stop. So here is a video of me doing it with my son. And so I go through each letter, and sometimes I vary it. Sometimes I do each letter in a row and then repeat doing each letter over and over again, or sometimes I'll just do the letter I 6 or 7 times. Then I repeat with the letter L 6 or 7 times. Sometimes it just depends how I'm feeling, but the idea is really just trying to get some movement through that colon. And my son, you can't hear the audio, but at the end of this, he tells me how relaxed he feels after I do it. You can also do it with lotion. just to help make it a little easier. You can also do it with over their t-shirts or whatever, their pajamas, whatever they're wearing. You don't have to be directly on their skin. I just find it's a little easier. And I also often have parents do it on their kids right before they sit on the toilet, so that you've kind of moved everything into position. So this is just one of my favorite stretches for releasing the pelvic floor. Some of you might recognize this type of stretch called Happy Baby. It can be good for kids, but it really helps to release the pelvic floor muscles. You can have them do breathing at the same time. Just tell them to try to relax their bottom as they're in this position. You can have them hold it for 30 seconds or a minute. And I will say that shortly after taking this photograph, my son was like, I need to go to the bathroom, and he ran. So I know that it can help. So this exercise here is called cat camel. Again, quite a familiar exercise for a lot of people, but what it's going to do is it's really going to help to increase trunk mobility, which can be really helpful. So you're going to see me cueing him a lot because he starts to kind of fade away. So I'm just trying to keep him in that quadruped position, and then cue him we want to arch the back and round the back. So I'm telling him actually do a rainbow here, and then a reverse rainbow or an upside down rainbow. And this isn't an exercise he was accustomed to, so he really needed me to help him and cue him for it. But it's a great one to get some good trunk mobility, which can help to improve the movement of stool in the large intestine. So next, usually after I have them do the cat camel exercise, I'll have them come down into child's pose. So this is also just another great way to get some good relaxation and even of the pelvic floor, but they can also do breathing here. And it's just a nice way to get a kid to calm down. So you can have them sit here again for 30 seconds or a minute and just do some calm breathing. Then next we have wigwags. So this is a good core exercise as well as one to improve mobility around the trunk to help with motility of the colon. So I also call these knee high fives, and you'll see me place my hands to help cue him and just give another example or a fun way to engage the children is to do knee high fives. So the knees stay together, and it's just the trunk that's rotating, or I should say from really the trunk down. The upper body is staying in place. That's why his hands are spread out like that to help stabilize him. So those are wigwags. Next are bridges. Bridges are great because they're great for core strengthening, for hip strengthening, and which is all going to be helpful for the pelvic floor as well. And so you're basically lifting your bottom up and down. To help get kids engaged with this, I will sometimes drive cars underneath them, say open the bridge, and they lift up, and then close the bridge and they lift down. So as he's going, you see his knees start to get a little farther apart. So I actually bring a ball over and have him squeeze a ball between his knees to help stabilize him a little bit more and to keep his legs where I want them. And with a lot of these exercises, the better a child gets with it, I will also start cueing for how they should breathe during the exercise, depending on the age of the child and how compliant they are. So yeah, he's doing pretty good. The arms can be down initially, but if you want to add a bit more of a challenge, you can have them cross their hands over their chests, and that will also give them a little more instability and challenge them a bit more. So this is a fun exercise. Kids really love this, and you can get them to engage with this quite a bit. I apologize that some of the pictures a little cut off at the top, but you'll get the gist of it. So this is for core strengthening, and it's kind of like a lot of the typical core exercises that we do. We're trying to make it a little more fun for kids. I call it foot basketball. So the child lies on their back. I'm going to hand a ball to him, and he's going to grab it with his feet, and then he's going to drop it into that that bucket looking thing over to the side. So you'll see me come over. You can use balls, you can use stuffed animals. I've even had larger block type toys, and I've had them stack blocks on top of each other and then stack them down, unstack them, or knock them down with their feet. So you can see he even gets a little bit of a crunch in there. That's not a requirement, but in a way that's going to get a little bit more abdominal activity. Just make sure if they are doing it that they're not really doing their neck too much. The way his hands were behind his head, he was definitely pulling on his neck a bit there. So just watch for that. So the clam exercise, another PT favorite for hip strengthening. So they lay on their, they lie on their side and open and close their knees like a clam. So watch his hips. He's kind of rocking them backwards. So I come over and just tell him, try to keep your hips where they are. Don't let your hips move. And then he does very well. He slows down, but then towards the end, he starts to get smaller and smaller because I think his legs were getting a little bit tired. But you can also engage kids. You can say it's a butterfly exercise. You can, sometimes I'll have the clam eat something like a ball or a toy or a car, and I'll have the kid, okay, open the clam's mouth. I'm going to throw in some food, and then the clam has to close its mouth. And so there's definitely lots of ways that you can engage the child, but just really make sure that their whole trunk isn't rotating backwards. That's a common mistake that's made when lots of people are doing this exercise. So you want the leg to open and close as much as it can without the trunk moving. So I think these are my last 3 exercises, are a series that I call animal walks. So just getting your kids to move around like some of our animal friends out there can be really beneficial for core strengthening, pelvic floor, hip strengthening, and just general mobility and function. So the first one is frog hops. This is one of my favorite exercises to give kids because it gets them into that really deep squat, which we've been talking about in all of our lectures, how important a deep squat is to really help lengthen the pelvic floor. So the child's getting into a deep squat where their pelvic floor is ideally a lot more lengthened. And then once they start to jump, they're going to have to contract their pelvic floor to help stabilize their pelvis. So it's a great coordination exercise for the pelvic floor. To go from a lengthened position and then have to contract and shorten that pelvic floor for a good solid jump. So frog hops are a great one. I cue them to try to keep their head lifted. I don't want to see them looking at the ground too much. I want to try to keep them upright. I prefer their feet to be flat on the ground. You'll see as my kid's doing it, he's got really tight ankles, so he doesn't really get his feet flat on the ground like I'd like, so that's something we should be working on. And that's the same for squatting. I didn't include it in this lecture, but I do a lot of squatting with the children. Usually if we've gotten toys out, their job at the end is to pick all the toys up, and they have to do a good squat for me to pick each individual toy up off the ground. And I'm usually having them keep their feet flat and trying to have them bring their bum as close to the floor as they can. So that's a great way to get some exercise in for both children and adults, is when you're cleaning the toys up at night, is to do a good squat. So bear crawling, a great one for the core, and for just general core and upper extremity, lower extremity coordination. This is a bear crawl. And yeah, so I like that. I'll have them do that up and down a hallway. Sometimes they're collecting little things for an obstacle course. There's lots of ways to engage kiddos with these exercises. And last animal walk is a crab walk. So this is also a really great one for core strengthening. You'll see he starts out pretty good, and then you can tell he gets tired at the end because his hips get more bent and more bent the farther he ends up going. But this is a tough one, even for adults. I'd say it's a great exercise to be working on. So that is crab walking. All right, so last slide here is some helpful resources that I would hope that any of you who are really going to be looking for more information on helping your child if you have concerns for bowel or bladder problems. There's a video, some websites and books that you can look into. The videos on YouTube, look up The Poo in You, and it's a great one on constipation and fecal soiling, and it really helps to, even for kids can watch it too, and it really helps to describe what's going on, and there's some good video of it. Websites. I love the website it's called ERIC, the Children's Bowel and Bladder Charity. It's actually from the United Kingdom, but I find that they have a lot of excellent resources for parents, for medical professionals, for teachers. There's all kinds of resources and great videos and ways to engage children. So I do love that one, but it is in the UK. So, so things that I think they might sell some things, obviously probably don't want to order things from the UK. But there's also the International Children's Continence Society, which is another one that has lots of great resources for parents and medical professionals. For books, for parents, I highly recommend It's No Accident by Dr. Steve Hodges. It's going to talk about both bladder problems and the link to constipation. So it's a really great book as a reference, and it really is highlighting how most children don't have any control of it. It's not an accident, that there are things that you can do about it to help with these problems. And then a book for the children. There is a pelvic PT named Janice Mitchell, and she has done a book for children about pelvic floor dysfunction, and it even highlights some of the things you would end up doing in pelvic physical therapy with a child. So that is a good one for the kiddos. So that is it for me and my talk, and I just wanted to shout out a thank you to my 5-year-old son, who was a good sport during all of this. So yeah, that's it.